Welcome to The Whole Pineapple. I'm Ruby Boris.
And I'm Ann Judge. The Whole Pineapple is a podcast about wellness focused around fertility. We'll talk with experts on a wide range of topics, including nutrition, stress relief, sleep, mental health, etc.
And we'll dig into the issues that can cause fertility challenges, like PCOS, or early menopause, or cancer treatment.
So if you're curious about your fertility, whether you're ready to start a family,
or you're preserving your options for the future, let's dig in. Hello, Pineapple Crew. Thank you for joining us today. I'm Ruby.
I'm Ann.
And instead of doing a lot of intro today, I'm just going to jump in and just give a little bit of a trigger warning. We're tackling kind of a difficult topic today, difficult but important. So nightmare scenarios for most of us. We are going to be discussing pregnancy loss and termination of pregnancy for medical reasons. So if that's not something you feel like you have the capacity for in your head or your heart right now, please go ahead and skip this episode. It will always be here if you want to come back to it later. You want to take care of you, boo. And we will be sharing some resources throughout the episode, but they will also be in the show notes. So if you want to look for them there, they will be there.
Who do we have today?
We are talking to Dr. Julie Bindeman, the licensed psychologist specializing in reproductive and fertility psychology. She is founder and co-owner of Integrative Therapy of Greater Washington, D.C., not Washington State.
That's a pet peeve for us. Anytime I'm reading articles and they're like, in Washington, I'm like, that's not in Washington. So.
It took me a second. I was like, why are we talking about Maryland right now?
So to be fair, I feel the same way about your state. When they're talking about Washington, I'm like, Seattle, who cares? It's coffee.
Yeah, we're the capital.
It is pretty funny that Washington's stretch goes all across the U.S., right? Even out here, we're like, we got to honor it. Although we think he had infertility, right? Because, that's so we gotta put that out there too. It's always relevant for our podcast. But I digress.
Yes, we digress.
Which is the podcast, basically.
Yeah, it's our entire podcast. Julie received her doctorate from George Washington University. She has served on many professional committees, including the Mental Health Professional Group of American Society for Reproductive Medicine, ASRM. She was elected to the Executive Committee in 2021 and is the former board member of the Maryland Psychological Association for 10 years and was recently awarded the Carl Heiser Award for her legislative efforts on behalf of the field of psychology. She's also authored and published several book chapters and articles pertaining to reproductive psychology. So she is an amazing person to talk to.
Yeah, we are so fortunate to have you. Thank you so much for coming on the podcast with us.
Thanks so much for having me. I'm so excited to be here.
We're planning to save your personal story as our snack because, as you mentioned when we were first talking, we don't want that to become what the whole episode is about. But obviously, we probably have to have a little bit of background to understand how you came to focus in this specialty area. So do you want to start by just kind of telling us about how you ended up having this as an area that you're now doing so much work in?
Sure. So like many of my colleagues in the field, didn't even know this was a field in psychology, a specialization in psychology, until I began my own family building journey. And at that point, I started training in perinatal mental health after I had my first child because, that dawned on me that that's a field in psychology. And I was really interested in it and really enjoyed working with new parents in that transition. And my partner and I had our own secondary infertility journey, which opened my eyes into the world of infertility and pregnancy loss. And so I decided to be responsible and obtain competency, which is more than just been there, done that, and got specialized training in the field and continue to do so and started to work within this capacity. So that's the really short story.
And what is your role now? Like, what are you doing in terms of your connection with clinics or, why do people end up talking with you?
Infertility sucks.
Yeah.
Yeah, that's the general theme.
You really need like a big sweatshirt that just says that.
Maybe that's it.
That should be our tagline.
Yeah.
Actually, I think, isn't that a hashtag? Yeah, I think it is. Infertility sucks. Yeah.
So because of that, people come and see me. In a lot of ways,
Yeah.
I'm really sorry that there's a need for someone that does the work that I do. Also, it is something that I love. I love being able to support people. I love to help people heal within this journey and whatever healing looks like, which as much as we all would love that to be a take-home baby, that's not necessarily the ending that everybody gets. So really being able to look at healing, this is a series of losses. This can be considered trauma as well, enabling people to become empowered, even though this is where their story has gone. So that's what I do. Also, people come to me for third-party stuff. So it's really fun to wear that hat in terms of being able to educate potential intended parents and potential donors and potential gestational carriers. I love, love, love doing that work as well.
And since you are on the opposite coast, I'm always so interested in other clinic structures, because one of the things that we talk about is how I think that everyone in treatment should just be seeing a counselor. I feel like that should be like a routine part of the process. And I feel like it's still hard to normalize that. And so I'm always curious, do people only come to see you because they've eventually had a referral after a lot of strains, or are you working at a clinic where it's integrated and just like expected that it's part of the process?
Having mental health embedded in a clinic is more of an older idea than something that clinics are pursuing currently. What I've been noticing, particularly around all the venture capital that's coming into this area, am I allowed to say that? And
yeah,
things tend to be outsourced. For me, because I'm a standalone mental health facility, that works for me. But also it does make it more difficult because I don't get to know the docs in the same way that I might if I was embedded, or the nurses, and being able to help staff, because it's not like you all don't experience any kind of secondary trauma from the work that you're doing on a day-to-day basis. So, that's the part I would love to be able to do more in, but really trying to create the relationships through ASRM, through the different kinds of opportunities I have through podcasts like this, and being able to use those relationships so that I can help other people. And whether it's me or my team, because I also train mental health professionals to do this kind of work, which I think is so important. Even if it's not a focal area, you never know when it's going to come into your office.
We had so much to talk about at our initial meeting. I'm actually having a hard time deciding which direction to go.
Me too. I'm asking all the questions. I'm going to pause and let Ruby decide what to ask. So,
well, I think, the majority of what we talked about were like some of the really challenging things that people run into, a lot of which they haven't had that discussion with, if they're a partner, they haven't had that discussion with their partner about like what would happen in this scenario. And then they're just faced with it all of a sudden. And one of the things we talked about in our previous meeting, getting ready for this podcast, was how important it is to have conversations about worst case scenarios. You're probably seeing a lot of patients after the fact, after they've reached a trauma, but do you talk to people about that beforehand?
So the context in which I talk to a lot of people about it beforehand is within that context of people who are wanting to be intended parents and going through third-party reproduction. It's definitely something that I talk about, and I talk about it in a really nuanced kind of way, because this is something that is really nuanced. Part of what is nuanced is everything that's happened since June of last year, where the landscape has totally changed. And what I'm talking about, just to, not be like beating around the bushes, we're talking about abortion. We're talking about terminating for medical reasons. We're talking about people who have very wanted pregnancies that for many legitimate reasons don't feel like they can continue them. It's like a double knife to the heart when you've gone through IVF. And even if you've gone through PGTA, and because I can't tell you how many of my own clients who are on infertility journeys, and I talk to them about this too, where they're like, it's fine. I have a PGTA tested embryo. We're good.
I think that's part of the reason that it's almost harder in a way now that we have the ability to test for certain things, because people think that we can test for everything, and you don't realize how limited our information is.
Right.
I'm explaining to people all the time, even if we've done PGTA and we know the recipe is correct, there's still that actual, the embryo forming from that recipe, and things can still end up not going correctly. And that is something that a lot of people, I think, haven't thought about. And I feel like there's probably also a little resistance to thinking about, as Ruby says, a worst case scenario, because you feel like, I don't want to put that in the universe.
Right.
I've had enough bad stuff happen to me. The last thing I need to do is worry about one more thing, because then what if it happens? I'll think it's because I was thinking about it.
Well, especially with infertility too, I feel like a lot of people, they get into the realm, they're like, I have to manifest this, because you're like literally doing all the things.
You're making a vision board, whether it's a real one with pictures or just in your head. You've got all
You're trying to do all the things.
So.
You're trying to get your brain in line, your heart in line, like your body, like, and it's hard, and they don't always work with
and
you.
You're explaining why I still have a job, because, it's not that. I think it would be in some ways so much easier for people if there were concrete reasons in which they experienced infertility. If it was true that, yes, stress causes infertility, so if you just go to Hawaii for a couple of weeks, you're good to go. Or like, if you just take this.
Wouldn't that be great? The government would fund our Hawaiian vacations when we were ready.
that would be amazing. It also wouldn't work. It's not medically based. And so I think that's the other piece that's so hard, is there is a limit. And I say this to people too. It's like creating one of those marble runs, and like you really hope, or like a Rube Goldberg machine, where like you really hope that when you put it in motion, it does all the things you expect it to do. But you never know at one point where like, oh, like there's a breeze and it knocked a piece out a little bit. And so the marble just stops. That's one of the ways that I think about it, is like, there's so many pieces that have to go right, and we can't be in control of them all. And that's the part no human really likes to hear that. So my clients especially, but I think that's the piece of acceptance, that when people can come to this idea of, this is not my fault, I didn't cause this, I can't control it. I can put things in motion, but I can't control the outcome I have after I've put the things in motion.
That's a really good way to explain it. And
I really
you're
love
right.
that.
It is interesting when you're talking with people that are going to be using a gestational carrier, and because you're having to drop all these contracts and you're having to explicitly talk about all these scenarios. It almost gives people permission to really think through those scenarios, because they have to, versus most people just mentally feel like that's the last thing they want to think about if they're not going to have to think about it. But then sometimes things come up and you're faced with, unfortunately, having to make decisions in a very small window of time, and often still with limited information.
Yeah.
And that's what can be so, so incredibly hard.
And really depends upon where you live in terms of, can you even make a decision, or are you having to make a series of other decisions because you either want more information and that's not available to you where you live? Some of my concerns that occurred pre-Dobbs, and my concern is that they proliferate, is, are doctors, do they become afraid to give patients information in which they might need to make decisions from? So whether that is a chromosomal anomaly, whether that is a structural anomaly, whether that is some kind of issue that's happening because the person who's carrying body is not able to be commiserate in this moment with pregnancy. Like, there's so many different reasons in which a person might have to make that choice. And it's a devastating choice, and nobody plans to be in it, particularly when they go through IVF.
I feel like in some ways so many areas of the field we're going backwards, but especially like you bring up, if we're not going to give people any ability to act on decisions, are we going to stop even doing anatomy scan ultrasounds? Are we going to kind of go back to 80 years ago? It's interesting to me, and none of us have the crystal ball. And now that we've had enough time go post-Dobbs, there are more and more of these stories. I mean, you read a story every week, because once they've gotten through the initial trauma of this, at least the articles you see, I mean, these women are angry. They're like, I should never have been put in this situation where I did not have choices available, where I had to spend money to fly 4 states away. And this gives people at least some focus and outlet. And so a lot of people are coming forward with their stories now. And I don't know how much that's going to move legislators, but it's been interesting to me to see how something that wasn't previously as talked about before is now getting more coverage.
I don't know if the challenge is moving legislators. I think unless we plan on moving them back home so they're not legislators.
Yeah.
And that's where I think our power is with our votes.
Yeah.
I'm sorry, I don't mean to
With our
sound
votes.
political
Yeah.
in that, but just,
No.
and what does this mean for IVF, right? Like, are we going to have more states like Louisiana that's like, no, actually a person starts at the embryonic stage, which means you can't store embryos in Louisiana because you're really going to freeze a human? Like, that's the thinking. I don't agree with that, but you know, we're seeing states try to do this dance around language where no, IVF is okay, but abortion is not. Don't know how successful they're going to be when there are advocates who want personhood confirmed at the embryonic stage, who want embryos to be considered as people.
Yes, every single fertility conference we've gone to since Dobbs has a panel, has a advocacy, and we've talked about it too. Yeah.
But this is why when politicians come into the exam room, it's hard to separate the politics from the discussion about healthcare.
Yeah.
So although I would love to not be talking about this all the time, unfortunately, it's a very real thing that's happening in the United States right now. And it's affecting a lot of people, and it's had far-reaching consequences. A lot of us did predict some of these things were going to happen, but a lot of the people that were making these moves, I don't think really understood everything that was going to happen.
Or all the downstream effects. I mean, you think about all the maternal fetal medicine specialists, all the physicians that are living in these really restrictive states. A lot of them are thinking about exit plans. And if I was a new grad, would I want to set up my practice in Idaho, knowing that I'm going to be severely limited and not be able to provide care? No, liability. So even just someone in the future that's having a very uncomplicated pregnancy is going to have a much harder time getting care there because you're really setting up all these guidelines that are not in line with medical knowledge. So we could talk all about that, but I know we want to keep the focus on your specialty. So
I'm just thinking too, like about the patients, right? Like these are actual people that are experiencing this. So you know, right?
In the background of all this, it turns out it's people. Yeah.
So do I want to still live in Idaho, knowing like, hey, if I'm of reproductive age, do I want to settle down in Idaho where I could be planning for wonderful pregnancies, but I don't know if, you know, there's the expression that man plans and God laughs. So like, what happens if the unthinkable happens? If I have an ectopic pregnancy? Well, that has to be medically managed in some way. Otherwise, my life is at risk. And maternity wards are closing in different states. Like it's, and I can't say that people didn't know because no, they were told. They just didn't listen.
Yeah, there again with the language, it's important.
Right. No, they knew.
You know? Yeah.
And to bring the focus back a little bit to what we wanted to talk, I know we can talk about all this. Like, let's explain a little bit what we mean when we talk about a termination for medical reasons. And like, I hate making this distinction between quote unquote elective abortion because I think that's a terrible way to look at it.
So actually, we're not going to make that distinction. I don't make that distinction to people because all abortions are elective. No one is coerced into an abortion. And if they are, that's a whole other thing that has so many problems in terms of domestic violence because abortions, just like breast augmentation is elective, right? Like, even if we're talking about, oh, we're doing a repair after a double mastectomy, like there's still an electiveness to it because there are some people who choose not to do that. So I think that's really important when we're thinking about language. And so I don't frame this as this is elective. No, this is an abortion. And I don't look at it too as like a first trimester abortion or a second trimester abortion. It is an abortion that occurs in the first trimester or an abortion that occurs in the third trimester or second trimester. So I think, and I'm sorry to be like on my hill about this, but like,
no, this is what I want.
Yeah, this is exactly what I wanted to talk about. Yeah.
Good. Because language is so important. And when we start with the second trimester abortion, and you know, it's interesting. Last week, a friend of mine passed away, and it was super, super sad. His name was Dr. Leroy Carhart. And I had the good fortune of getting to know him as a friend and getting to go out to dinner with him, getting to know his wife as well. And in the articles, in the obituaries written about him, it wasn't his work. Partially it was his work as not only a reproductive warrior, but also his work in performing abortions in all trimesters. But it was so interesting in what different news outlets decided to center on. And they're not centering on the fact that like his work was made increasingly difficult, not just because, people set his barn on fire or shot at him or all sorts of other things that he experienced in life, but just in terms of, he lived in Nebraska and he had to start commuting to Maryland in order to do his work, and not being able to take the same flight different weeks in a row, or not being able to stay in the same hotel because he was risking his life to help others. I found it so interesting in what some of the articles tended to center on. They might have been centering on a particular patient or a particular experience. And I'm like, well, we need to be centering on this man, because actually that's what the obituary was about. It was his life and his legacy. So that's why I'm coming back to this idea of language is important. And when we don't really center on language, then we start miscommunicating in terms of what is it that we're talking about.
Humans do this. We like to categorize things. So when we say something like first trimester abortion or second trimester abortion, it puts you in a category, and that's when judgment happens one way or the other.
Yes.
And when we use euphemisms, that's when we're separating ourselves farther from science. For years now, when I do my early ultrasounds, I never say, oh, we're here to hear the heartbeat. I explain from the very beginning, like there's no heart yet. We're looking at cardiac cells that are eventually going to form those structures of the heart, and we can see that electrical activity in ultrasound, and that's what we're looking for today. But I think the people that have been trying to restrict access have done a very good job of conflating emotional terms that might have no scientific basis and getting these things written into law. That's one of the challenges. You have some of these bans that are so vaguely written that they, as you said, totally could apply to embryos that are in a lab. If you're just defining life is beginning at conception, that has so many limits for what we do. And so trying to be as precise as we can about what's really going on, I think is something we have to do a better job of to make it clear what the stakes are.
Absolutely, because the stakes are high.
Yeah. So take us back to, if you're talking with a patient that's coming to see you because they've gotten some sort of diagnosis and they're having to decide what to do, how do you even begin to have that discussion?
So I like to frame it to people as this is the first parenting choice you're making, and putting it in that frame of what is it that you are able to do as parents, and how do you get the information that might lay out what the scenarios could look like. Because of course, as amazing as ultrasound is and MRIs are, it can't give us a sense of prognosis. It can tell us what we can see and what we expect, but it can't give us a sense of the crystal ball and this is what will happen. So it's not as definitive. And I think that's what is really hard for people, is that especially the diagnoses where they're not so definitive, that they're what I like to call the gray diagnoses, sort of that area of like, well, it could kind of go any way.
That's just fertility for you. Everything is gray, shades of gray. There's nothing black and white about what we do at all.
Yeah.
But I think people are often surprised how common that is a finding when you see something abnormal on ultrasound. It's like, well, yes, there might be this structural defect that in itself might not really could be correctable, but often that's associated with these other things that we're not going to know until after birth. And so you're trying to give people guesses, really, and there's not a way to know. And that's what I think what's so hard for people. I think people have this, just like we talked about testing the embryo, people think that's going to test for everything. People also think because we do have detailed ways of imaging that we can get definitive information. And that's often not the case, especially because we do have, even in states that are more permissive, there are still limits with viability. And so by the time that everything has developed enough to even do testing, you really don't have a lot of time. And that can be really hard for people too. There's so much information to absorb. Often the patients that I've had, they're flying across the country. They're seeing specialists. Like, they want all the information to make a decision, but often that information is still quite limited.
Our patients are often like right on it. They're getting their non-invasive prenatal testing. And again, with the PGT, they often don't realize that's a screening test, right? And then after that needs more diagnostic tests a few weeks later. Even then, you probably want more information, like Anne is saying, like want to get specialist testing. So then you're left with not a lot of time to make these decisions once you have the information, if you ever get the amount of information that you need.
I think what's really hard too is that, I mean, at least some of my patients will go to multiple maternal fetal kinds of centers, whether that's CHOP up in Pennsylvania or whether that's Children's National. They'll go to the places that have the most expertise in this. And sometimes the experts don't agree.
Yeah.
Especially when we're talking about a potential prognosis, there's not necessarily uniform because none of them are fortune tellers. And when we keep on thinking too about, well, here's what science can do, I kind of come back to the expression of just because we can, does that mean we should? Right? So just because there's like one or two babies that have had special kind of intrauterine surgery and it meant that they've survived to birth, well, what does the rest of their life look like? And what is that like as a parent? Again, I come back to what is the parenting boundaries that you and your partner, if you have one, are able to take on? Because I think that becomes a much more tangible kind of way of thinking about it. So, are you able to perhaps have to go to several doctor's appointments a week, your child's life? Are you able to, do you have health insurance that you can pay for potential surgeries that your child will have? Do you have some respite care for yourselves so that you two can still have a marriage, right? Or do you have other kinds of care who can help that you trust that can help with your child because you might need to go back to work? So there's lots of different things to think about in terms of what are our parenting boundaries around this? And there's religious boundaries that might come up. There is financial boundaries that come up. There is emotional boundaries. There's just that sense of capacity too. Like, what can we handle psychologically? And I think by framing it that way, it's a non-judgmental way of framing it, because I don't decide what other people's parenting boundaries are. They get to decide. So if they're sitting and saying to me, yeah, no, we're up for the challenge. We can handle a special needs kid. We can handle a medically fragile kid. I'm like, great. Then that comes into how do they make this decision?
I think your whole framework is such an important one of the first parenting decision, because I feel like the patients that I've had that have had terminated for medical reasons, I mean, it was such a wanted pregnancy, such a heartbreaking decision. And my one that flew and saw all the specialists, I still remember her talking when she came back and saying, at the end of the day, this was going to be a baby that was born that couldn't breathe. And that was going to be a very painful, most likely life-ending diagnosis. Yes, we could try all these things, but they had a low chance. And I think the kinder thing was to end this pregnancy, to never have that amount of suffering. And that was such a loving parenting decision. Yeah. And so to have anybody judge that, I'm emotional even thinking about it, because it's true. Like, these are not easy decisions for anybody, and people are making them because this is a child they love and they want the best for. And sometimes the best is not continuing.
The best way I've heard of framing it is you are making a choice to take upon a lifetime of pain that you're going to experience so that your child doesn't experience the moment. And it's that framework, like you are taking on this pain that your child would be experiencing. You are willingly and you're choosing to take it on so that your child doesn't have to even have a second of it.
Wow.
That's really good. Wow.
That's such a great way of saying that.
How else do you talk to people? I mean, it's feel like everyone must come see you in such a state of just shock and grief. And it's so hard to be processing your own emotions while also having to make decisions. Yeah. Like, this is not a great time to be thinking critically when you're just still reeling from it all.
And you're in shock, so you're probably not taking a lot of information in very well either.
What I say to people too is that, who's kind of like your counsel that you have together, that whose advice can you solicit of people that you really trust? Maybe that's family, maybe that is chosen family or friends. Who are those people? And help have that counsel who's not in it with you in the same way, be able to help give you some pieces of information or reflect back what you're hearing. But I also say to people too, is that the hardest part about it is there's no way to obtain all the information you would like. There's just no way, because sometimes that information is just not available until after the child's born. And as we've been talking about, there are time restrictions now in having to make a choice. And so I do like to frame it too as You are making the best decision you can based upon the information you have today. And that doesn't mean that after you terminate and you do some kind of genetic sequencing that you don't learn different information, but it's framing it in terms of you're making the best decision based upon the information you have today. And that's all you can do. It goes back to that sense of humanity, right? Like that we can't tell the future and we can't make these predictions, and that the tools that we have are also limited. And I don't think we like to feel limited. We want to have all of the facts, all of the information, all of the potential. How does this pan out? And we can't. There's going to be a limit to it. So it's being able to understand too, what is the limit I need in order to make a decision? And then knowing that I might get new information as time passes after the fact, but I made the best decision I could based upon the information I knew.
And I know we've focused mostly so far on fetal diagnoses, but you brought up earlier, sometimes it's about the health of the person who's pregnant. And that can also be a challenge because a lot of people are willing to put themselves at a lot of risk. Yeah. And sometimes there's a difference of opinion if they do have a partner, where maybe the partner's the one being like, hey, I'm hearing these really scary things from my physicians. Like, I don't know how I feel about this. So how do you approach more of those conversations?
I tend not to see that until after the fact, because most of the time, if we're at a place where physicians are weighing in and they're concerned, we're at a time where like there's not a whole lot of time to be like, what should we do?
To talk to the counselor.
Right. Yeah. Most of the time people get hospitalized by now to try to, you know, maintain stability as best as possible. The issue I am thinking of where I might see someone is with hyperemesis. You know, that's something that we don't really think or talk a whole lot about, because we have the expectation that when someone gets pregnant, a little nausea is not, you know, so far-fetched, or, you know, a little vomiting. That happens. That's not hyperemesis. Yeah, hyperemesis is not being able to keep food down. Hyperemesis is like, even if you can eat, it's coming back up, or it is extreme revulsion at the smell or the sight of food, or it is extreme nausea that, again, the idea of food is just untenable.
Those cases, when I worked in the hospital on antepartum, hyperemesis cases, those poor people.
Yeah. With the feeding tubes and the, you know, IV and everything. And Ruby, I can't remember if I sent you, there was a fascinating article a month or so ago in the New York Times about this researcher who's doing all this work on hyperemesis. And it was because when she was finishing up her own medical program, she was hospitalized and it was so severe and she had to leave her program and no one wanted to research it. And she ended up using a surrogate for a subsequent pregnancy because she was like, I seriously wanted to die. She's like, to feel like you're just nothing but constant vomiting all the time and you're so malnourished, and to have people sort of equate that with being a normal pregnancy symptom made her mad. And she's doing a lot of work into the genetic markers and really trying to understand it. And it also makes you mad that other people haven't been trying to understand it either, because it's kind of brushed off as an expected part.
Oh, you just have really bad pregnancy nausea. And it's like, severe isn't even the right word for it. It is so intense. They were the most miserable. Like, they were so miserable.
Let's call it what it is. It can be life-threatening, right? Like, I know people who are suicidal because they have hyperemesis. That's life-threatening.
And also, you need to eat and drink things.
A little bit, yeah.
To live. It is a thing.
Kind of important. Yeah. And we're not talking like a week or two. It's like
it's constant.
Potentially all pregnancy.
Yeah. I mean, I think about a client I had who had gone through IVF, who had so many different losses, was finally able to get pregnant, and then had the worst hyperemesis until she delivered. I think probably for her, if she didn't feel like this was her one shot, she might not have continued. And I know people who have made the decision to not continue because the hyperemesis was so awful.
And like so many other things in pregnancy, historically, it got blamed on the person. They were saying, well, that's because you're ambivalent about the pregnancy. Like, it's all secretly, we're going back to all the Freudian stuff here and blaming people for their own symptoms.
Or the other one that I heard a lot was like, oh, have you had a history of disordered eating? And it's like, that's not their fault either. But it's just like constantly like, oh, this is why you have this because you had X other thing. And it's like, no.
it's not a punishment for something you've done before. Like I've heard all sorts of things of like people trying, because I think we're trying to understand like why do some people get it? And I found sort of a non-scientific correlation. So I'm not trying to say it's causal, but I do think that there might be something to research around where people who will later have poor prenatal diagnoses tend to have pretty bad hyperemesis. And as I said, like, I don't know if it's causal. I've spoken to an MFM friend of mine and I was like, is this a thing? And she's like, it's certainly something I see a lot too. And she's like, I do wonder if it's something about the genetic markers in the pregnancy that already aren't wired in the right way, that's sort of communicating something to the body. But of course, there are times where people have hyperemesis and everything's fine. I'm not trying to say it's like 100% causal kind of thing, but it is something kind of interesting to think about.
Well, also, not to go too off topic, but the conference that we just did recently, my talk was on the weight loss medications and like our safety in terms of it comes to fertility. And one of the big things is that like, well, one of the concerns with pregnancy is you're not supposed to be actively losing weight in pregnancy. And so when they see concerns with some of the embryonic development and weight in mouse and female rats, is it because of the medication or is it because they were actively losing weight in all those early stages? And so if you think about people who are having hyperemesis this whole time, you know, it is really hard to be adequately nourished. And although we think that a pregnancy is going to pull from you what it needs and you're just going to feel miserable, it does seem like there'd be some sort of compromise in terms of exactly how well that pregnancy is growing too. So yeah, gosh, we have all the things we can talk about into all the different areas of scientific research.
I swear, like I can feel myself. I am back on the antepartum ward right now because all of those people, like they tended to have like, I mean, they're hospitalized for a pregnancy related issue, right? There were a lot of the decisions that we had to make regarding continuing a pregnancy or not. One of the most memorable experiences I had, I was a very new nurse. There was a patient with HELLP syndrome that was pre quote unquote viable. It was before like it would be safe to deliver the baby. I can't remember if she did fertility treatment, but it was very, very heart-wrenching.
I mean, sometimes I think we're lured in by the myth of modern medicine in the sense that we fixed all the things. Like you forget how dangerous pregnancy can be to your body. You know, at this conference, we had one of our MFM docs in the area speaking, and she's like, remember, pregnancy is a stress test on your body. You know, all these systems have to work so much harder. And so if you have someone that already has cardiac issues or blood pressure issues or all these chronic health conditions, sometimes pregnancy can push them into an unsafe place very quickly. And you're having to balance those needs. And sometimes the needs of the person who's pregnant to stay alive are quite important and outweigh this idea of stretching into fetal viability. But I know that's a really hard place for people to have been in, especially if you're mostly seeing them in the after effect. I assume, just like what we were talking about with fetal diagnosis, this all happens so fast. You don't really have time to process. Right. And often you're unconscious and in the ICU and your partner's making the decisions and signing the forms. Right. And by the time you've hopefully recovered, all of this has happened to you. And that has to be so hard to try and even wrap your head around.
I threw around HELLP syndrome, like everybody knows what that is. Yeah. It's a life-threatening pregnancy condition that you cannot wait. It is the person carrying the pregnancy will die if it goes untreated.
The liver basically shuts down and then multi-organ failure. Yeah.
Yeah. You can't clot.
And the cure is get rid of the placenta. The cure is delivery.
This is one of those rare areas that are black and white. It's like, no, this will happen if we don't treat this. The person carrying the pregnancy will die. So
I think that's like mirror syndrome. If the cure for mirror syndrome is delivery, I think that's for so many of these things that we're talking about that impact the pregnant person is something that delivery is the only thing to do.
And the challenge, especially with all these states with bans now, is, you know, sometimes someone is very quickly trending downhill and you know that death is imminent. But many places, it's more like, well, at some point you're starting to have these signs, but maybe we can get another 2-3 weeks and maybe that pushes into that window of viability. And that's what's put medical providers in all these states in really hard situations, because some of these only have exceptions for imminent life and death situations, and they don't allow you to have this clinical discussion about here's what I'm concerned about. And so, I mean, that's why you have all these sad stories of people being told, yeah, they told me to wait in the parking lot. And if I started really hemorrhaging, then I could come back in the ER and they would help me.
Yeah, it's all context too.
Oh,
So like
yeah.
what is quote unquote imminent life threatening in
Mm-hmm.
like a pregnancy situation is be completely different for somebody that if you told somebody that's not pregnant, you're going to die in 3 weeks, that seems pretty imminent to me. Like
Right. And then what is it that you want to spend those 3 weeks doing, right? Just sitting there being like, it's fine. Let me see how I feel about this. It's like, no, I'm going to be getting second opinions. I'm going to make sure that this is what we have to do. If it is someone that I'm already seeing, because certainly I've had those cases too, where it's someone I've already had a relationship with, and then they find themselves in one of these circumstances. And then we can talk about like, okay, like, let's think about these 3 weeks as memory making, right? Like, this is something that you're going to have to do to make the memories that you expected to have a lifetime to make with your child. But unfortunately, that's not the case right now. So also thinking about like, how do you still have that identity as a parent when you don't have a living child to show for it, when you don't have that kind of societal marker or that really obvious thing that's like, I'm a parent, right? But I look at when we lose a child, whenever or for whatever reason, we're still parents. And how do we honor our parenthood? And how do we honor and remember that child too? And that becomes some of the work that as a bereaved parent, they might choose to do.
Well, I think let's all take a big collective breath right now.
Yeah.
It's a lot.
This is hard. It's a lot. So,
and we're definitely not expecting you to come on in 45 minutes and tell us all the things. Obviously, there's so much, but this is a perspective that doesn't get talked about enough. And I appreciate so much you sharing everything you've been talking about with us. Any other key things in this episode that you want to kind of educate the public about? This is your hill. You can talk about whatever is most important.
I mean, you might be really sorry you gave me that offer.
Well, just to take some of the pressure off you, I did want to briefly touch on when people have to make the decision for, well, what we call selective reduction of multiple pregnancies.
Yeah, so that's another kind of terminating for medical reasons. And it's different than a multifetal reduction. So I love how people always lump those two together. But just to define for people who might not be as geeky as us, a multifetal reduction is when someone is carrying a multiple pregnancy, whether that's twins, triplets, quadruplets, etc., and decide that that is more children than they want to have. And so they will reduce the pregnancy.
Or more risk than they want to have. Because often it's not about, they would love to have 3 children, but they don't want to lose all of them at 23 weeks. So,
that's very, very true. So it's both of those things, right? More risk that they want to have or more children that they want to have. And so that they will reduce. And it's not because there might be anything, quote unquote, wrong with any of the fetuses inside. But again, this is a parenting decision that's getting made. So I put it back in that framework. Whereas selective reduction tends that there is an issue, whether it's within the pregnancy of multiples or it is within one of the fetuses in a multiple pregnancy, where it makes sense for the health of the entire pregnancy to reduce that one fetus to better give a chance for the fetus or the fetuses to be able to make it to term or as close to term as possible.
And this is another thing that there are not exceptions for in all these laws, post-ops.
No.
And so people that are in states, we as fertility have to think about this a lot more now. Like even people doing low-tech treatment, they're taking Clomid or Letrozole, but they're going to ovulate multiple eggs. We probably should be having in a more detailed discussion about risk of multiples if we don't have any options, if people become pregnant with multiples who don't want those risks that are associated.
Well, and I would add another piece too that we don't think about is ectopic pregnancy, because even with IVF, someone could still have an ectopic pregnancy. It wouldn't be on the fallopian tube. It would be potentially in the cervix or elsewhere. But
it can go in the fallopian tube. I've seen it.
And it can be in the fallopian tube. We
true.
can put it in the uterus and it can like move its way on up anyway. We've seen it.
It floats on up there sometimes. Yep.
Okay.
Yep.
Yeah.
I've seen it right next to the ovary before. So
wow.
And it's so hard because people are like, but they put the embryo in my uterus. It's like, I know, and it should burrow it right there. But sometimes, especially if it's a tube that's damaged, and so all those little cilia inside aren't working the way they should, it's just easier for everything to kind of go up in the wrong place.
It's so hard. Yeah.
So in ectopic pregnancy, we know that pregnancy can only grow in the uterus because it is a magical organ that has the ability to expand in a way that no other part of the human body can. So the fallopian tube can't do that. The cervix can't do that.
The C-section scar
can't do that. Right. All of that's important, and it can cause death. It will cause death if it's not treated. The only way to treat it is to remove the pregnancy. And by the way, it's not a thing to be able to move it back into the uterus. Like, here you go.
For the record.
Not like a wayward child getting out of bed at night,
Which
right?
we have to bring up because lawmakers have brought that up as an example of like, couldn't we do this instead? So
I kid you not, I screamed with that one.
Yeah.
I mean, that's a question that patients have asked me all the time. It's hard. If you don't work in medicine, this is not your field. Like someone's telling you that this wanted pregnancy has implanted in the wrong place. It's a very natural thing to say, well, can't you move it? You know, like we can transplant other things in our body. And so this is what happens when you have people that aren't in the medical field making medical decisions, is that there's lots of things that intuitively might seem like they're a thing, but they're not a thing. Yeah. And that puts people in really dangerous situations.
I think if we're getting back to the idea of like, what sort of things do I want to leave people with? I think what's really hard is that oftentimes when you terminate for medical reasons, it is not necessarily seen by the rest of the baby loss community as a legitimate loss, because of the idea that, well, you chose this loss versus me who had to endure this loss. I didn't have a choice about it. If I had a choice, I would choose not. I would choose to have kept my baby. It's like, well, yeah, no, all of us actually would have chosen to keep our babies. And we're in a situation where we had either our own bodies or our babies' bodies that weren't bodies that could survive. And so, you know, we are making these kinds of parenting decisions. So I want to just put a light that it is a legitimate loss. I also want to share about there's an awareness day for terminating for medical reasons, or also called TFMR, which happens to be May 4th. So may the 4th be with you, but also...
That's the day we're recording this. I know it's going to come out way later for those of you listening, but today is actually May 4th.
I thought about that this morning. I'm like, what fortuitous timing.
No kidding.
So being able to recognize that this is a loss and that there needs to be awareness about it, particularly when states are taking away medical options for people to make. I think also what becomes really hard, and when we get back to language, is many people consider this the loss of their baby, not the loss of a fetus. And I think that's something too that becomes really hard when we're discussing all kinds of abortions, because fetus kinds of puts some distance to it, whereas baby puts more closeness and relationship to it. And so I go with what my patients feel. Like if most of them feel like it's their baby, and so we talk about their baby, it's legitimate, right? And just because it was a choice doesn't make it illegitimate, that it's still a legitimate loss. There are parents that are devastated. This is something that can end marriage, just like a lot of pregnancy losses can be marriage enders, because people grieve so differently. This is something that can haunt people for years. It's not the abortion that tends to be haunting, although there are the rare cases where there's such trauma in what the delivery looked like. But more so what people tend to be haunted by is having to make the choice in the first place, or having to navigate a system in order for them to make a choice. Those tend to be the aspects that are traumatic, not this idea of, well, it's bad because abortion's bad and it has terrible mental health outcomes. Also debunked in the literature, by the way. I can point everyone to an amazing book and an incredible study that's ongoing by Answer out in San Francisco, and it is called the Turnaway Study. And what that study has found time and time and time again is that abortion doesn't cause any kind of mental health issues. So it also doesn't cause infertility. It doesn't cause cancer.
I was just going to say, it does not cause, if you have a miscarriage later on, that is not why.
Correct.
But one thing that can cause fertility difficulties is making these pregnancies go on longer than they should. When we're talking about things like ectopics, or we're talking about things that are threatening the health, the longer that pregnancy goes on, molar pregnancies, like the longer that these situations happen.
Or if you have to make a potentially unsafe decisions.
Yes.
Yeah, like those are the things that really can impair your future fertility. So if we're thinking from a perspective of wanting to increase the healthy children that are out there, these are not reaching our goals in any sense. And I'd imagine one of the other things that has to be so hard for people after is what we mentioned earlier, that gray and uncertainty. I'm sure there's a lot of people that go back over later, like, well, what if I'd known what I found out once I got this other information? So I think you're so right to bring it back to you making the best information you can at the time with the information you have available to you.
Yeah. That these are parenting decisions, and you can only do what you can do with what you know, just like in any decision, right? Like if we're thinking about where do we want to go to college or what kind of career we might want to have, like you can only make that decision based upon what you know at the time. Now, it might be that 20 years later, you're like, well, that was dumb, but you know what? You didn't have that 20 years worth of information at the time.
No, I think those are definitely the key things I'm taking here, that framing it as a parenting decision, accepting that you're happy to use the information you have. And you're right, this openness and this talking about it, because it's such a hard thing to go through. And any sense of shame, we need to keep things secret. I mean, that makes it even harder to just be your authentic self. And you're right, these are parents, and they have had to make a really, really hard decision.
Absolutely.
And at the beginning, I mentioned that we would have resources. Do you have any of your best resources that you can share with us? There
are some great books, because I think one thing that happens for a lot of the people that I meet with is they feel so alone. This is not something people are talking about. This is not the miscarriage that 1 in 4 of their friends have. That's something that's much more common. And so there's this sense of isolation. So there are some really wonderful books like Flowers in Our Womb and Our Heartbreaking Choices. Those are 2 compilations of stories written by people who have experienced terminating for medical reasons, for all different reasons. There is great websites, and there's one that's called like 1in10blog.wordpress.com. Gosh, I feel like I'm reaching from the anals, but also those are more abortion stories for people that have terminated for medical reasons. There are some wonderful online support groups. Ending a Wanted Pregnancy. You get vetted in order to join that community, which is really important to keep it as a safe community. A Heartbreaking Choice is another community. There's podcasts that are dedicated just to terminating for medical reasons. So Time to Talk TFMR is one that's great. It's on the other side of the pond. So they recorded in the UK, which is awesome. But that's a great place too to listen to different stories and get information about. And then I'll make a shameless plug that if you are a mental health professional, next year I will have an edited book coming out about the mental health professional's guide to abortion care for their patients.
And that actually goes right into my next question is like, where can people find you? Either potential patients or people that want to learn more, or all the above.
My website is greaterwashingtontherapy.com. That would be Washington, D.C., not the other Washington. Sorry, can't help it.
Can you see people in variable states, though?
So I'm part of SciPac, so I can see people in 34 states and counting, because there are more states that are applying to join SciPac, which is pretty cool. Other ways to find me, until Twitter dies, I will be on Twitter. So that's at Dr. Julie B. I feel like I am just like, as the ship is sinking, I'm still on it. Certainly on LinkedIn. I'm on Instagram, Dr. Julie Bindeman. I have to find a new home outside of Twitter, so we're playing around with Post and Mastodon. But
you're gonna start doing TikTok videos?
I'm on TikTok, and I have to ask one of my kids to teach me how to do it.
I haven't been able to figure that one out yet. Oh man.
I can't either. So maybe it depends on how much brain power I have. But maybe Spoutable. That's one that I'm looking at too, in terms of.
I don't even know what that is.
No.
It is supposed to be a better, more secure Twitter.
Oh.
All right.
So, yeah, we'll see.
More to come. We'll definitely hope people tune into your shorter episode where we're just going to talk a little bit more about your journey, because you have quite a story too. And I appreciate you being willing to share all of that with us today, as well as all your expert information that you gave us today.
Thank you so much.
Thanks for having me.
Thanks for joining us for this week's episode of the Whole Pineapple Podcast. We hope it was helpful.
If you know someone who could benefit from hearing the podcast, we hope you'll share it with them.
And don't forget to subscribe, rate, and review The Whole Pineapple on your favorite podcast app. Every rating and review makes us easier to find.
This podcast is sponsored by Seattle Reproductive Medicine and is produced by Audiotocracy Podcast Production. We'll see you next time. Have a delicious week.